processes in which we're getting the oxygen from outside into our cells, the CO2 from the cells to the outside, right? So we divide it kind of three, I won't say, I don't know, steps is the right way, or processes, right? The step sounds like it has to be in that order, it's not really in this order. Well, pulmonary ventilation is the act of getting the air from the outside into our alveoli and then from the alveoli to the outside. Right? So it's kind of breathing. We talk about inhalation, exhalation here. I'll expect us to be able to list the order and the events that happen that causes or drives inhalation and exhalation. Then in terms of exchange, we talk about two sites. One is at the alveolar, so that's called external respiration, where we transfer oxygen from the alveoli to the blood, and then CO2 from the blood into the alveoli. Right? Internal respiration, that's happening with the tissues, kind of the opposite direction. So from blood, oxygen goes into the tissues, into the cells. From the tissues, CO2 comes back. Okay? So we'll talk a little bit about what's driving this, right? So we'll talk about partial pressures and partial pressure gradient, or difference in pressures. And then transport, we have to transport the oxygen, we have to transport CO2. So it's our circulating system that does this. We'll add, I think we mentioned about the oxygen transport. What are two ways in which oxygen is transported in blood? More detail than just, yes, it's in erythrocytes. How? Is that what you said? It's bound to hemoglobin, right? In erythrocytes. Good. That's most of it, 98%. How else do we transport oxygen? About 2%. Is by blood plasma. Thought I was in the first exam. We'll talk about it. But carbon dioxide, I don't think we'll talk about it. Three ways in which we transport carbon dioxide. Okay. So first of all, let's talk about some terminology. Hypoxia basically means decreased oxygen. It doesn't tell us where, but usually we mean hypoxemia. But we can also talk about tissue hypoxia, right? Which is, we're talking about the tissues itself having less oxygen, right? But if we have hypoxemia, it will result in tissue hypoxia. Not all tissue hypoxia is because of hypoxemia, right? If we have edema in an area, blood may bring oxygen, it just will not diffuse. So it's hypoxia. Okay. While anoxia here is when it's really low oxygen in the air. This happens when we stop breathing, or that tracheal obstruction happen, and then we are not able to exchange air, and oxygen is cut off. So let's talk about pulmonary ventilation. Just before that, again, a couple of terms: respiratory rate versus cycle, right? So respiratory rate is how many times we inhale and exhale in a 60 seconds or 1 minute. Right? A respiratory cycle is inhalation followed by an exhalation. Right? Kind of similar to in our cardiac. What was it similar to? Stroke volume, and then cardiac output. Right? So volume is pumped out to 1 versus volume pumped out to this is kind of similar. But here it's not. Volume is more times it's doing in what it does. So let's talk about what allows our lungs to be able to expand. Right? So first we'll talk about this pressure gradient in a little bit. Pressure gradient is similar to concentration. Right? So things will, we're saying it moves down, pressure always moves down. It's going to move from a high pressure to a low pressure. Right? And we'll talk about that. That's what plays a role in that in the external respiration as well as internal respiration. And we're going to talk about in terms of our ventilation, in terms of Boyle's law. Okay? Boyle's law talks about how when volume changes, pressure goes in the opposite direction. So volume increases, pressure decreases. Okay? And then volume decreases, pressure increases. Right? I gave an example of the syringe. We push the plunger in, we're decreasing volume, pressure increases. You've got a cap and you pull the plunger out, volume decreases, volume increases, pressure decreases. We'll talk about that, right? And we'll talk about how in exhalation I'll expect us to be able to explain the process, what happens in which order which causes this change in volume and hence pressure. Compliance, this basically means the ability of the lungs to stretch and coil, right? So normally we can increase compliance, but illnesses can, especially for example, can decrease compliance. Like you may have heard of a disease called sarcoidosis, even lupus sometimes does it. It's going to put connective tissue without those elastic connective tissue, other connective tissue, hence regular connective tissue, they will put areolar connective tissue within the lung tissue, right? So what do you think how will that affect air compliance? Yeah, it won't be able to expand and relax as easy, right? So compliance will decrease. So compliance is the ability to nicely expand and relax or decrease the size. So let's talk about inhalation, okay? So please be able to list the muscles involved, what's happening, describe also the volume changes and pressure changes. So during normal restful breathing, it's only two muscles that are involved. What's the first one? Hopefully this one you'll tell me. Diaphragm. What's the other one?
Intercostals.
And yes, it's the intercostal, it's the external. We have an external and an internal. So it's these two muscles, external intercostals and the diaphragm that provide restful breathing, okay, or result in restful breathing. So be able to describe this, please. So diaphragm goes from a dome shape. When it contracts, it goes to a flattened state. Okay. So I'm going to draw it as a 3D. Hopefully you'll see that also increases the area. So this is the chest wall of the outer. Say if this was the diaphragm. Okay. It goes, I'll make it even more obvious. It goes from a dome shape, okay, to a flat shape, flat state. Right, so it's going down from a dome shape, it contracts, it flattens. Right? As you can see from this image, this was the area which translates to volume of the lung. We've just added this extra space. Okay? So what's that doing to the volume of the thoracic cavity? Increasing it. Another thing, now let's do a deep inhalation so you can see it more dramatic. But this is what happens when external intercostal muscles do. They're going to move the ribs outwards and upwards. So, and then what's happening to the diaphragm? It's going downwards. So all of this, so the external intercostal muscles also contract. When they contract, they're going to pull the ribs and the rib cage outwards and upwards. Okay? Both of these two increase thoracic volume. When thoracic volume increases, what happens to lung volume? Increases, right? So when volume increases, what happens to pressure in the lungs? Intrapulmonary pressure decreases. Right? That's Boyle's law. When volume increases, pressure decreases. So I have less pressure here compared to the air here. What happens then? Air moves in. Please be able to describe. I'll either ask inhalation or exhalation. Include the muscles involved, what's happening to the volume, why is it changing as well. So diaphragm going from dome shape to flatten, external intercostal muscles when they contract and pull the ribs outwards and upwards. Both of these increase volume. When thoracic volume increases, pressure decreases. So the air moves in from a higher pressure outside to a lower pressure inside into the lungs. Okay? Opposite happens during exhalation. Here, again, this is restful. All that happens is the diaphragm goes from this flattened shape to a dome shape, relaxes. External intercostal muscles relax. The rib cage drops down and inwards. Both of these, what do they do to the chest volume? Increases, hence lung volume decreases. So chest volume decreases, lung volume decreases. What happens to pressure in the lungs? Intrapulmonary pressure increases, and now inside has more pressure compared to the outside. Air will just flow out. Okay? Please be able to explain both of these health secrets. This is during restful breathing, right? Just these two muscles that are used. But in forced inhalation or forced exhalation, whether it's because we're forcing it voluntarily, or when an illness happens, right? We're going to use what's called the accessory muscles. Okay? What are some of our accessory muscles? Let's talk about first inhalation. One we mentioned in lab, muscle lab. We'll talk about that in a second. Pectoralis minor, that's going to lift during inhalation, that's going to lift it up further. Even sternocleidomastoid also plays a role, so remember the clavicle is the cleido, so lift that up too. We also have the scalene muscles, which we didn't talk about. All of these will lift upwards. Okay? So what does that do to the volume of the lungs? Increases it further. Whereas when we're trying to blow out a candle, think about what you're doing, right? What's happening in terms of muscles? One you may not have noticed, but the second one you may have.
Your abdominal muscles?
Yeah, the abdominal muscles contracts, right? Right, it's going in, which means the thoracic volume also will decrease, pushing everything down. Okay? Because it's going to increase the pressure. That's during exhalation. So abdominal muscles, and then the internal intercostal muscles also contract. When they contract, they're going to pull the rib cage even further inwards. So what happens to the volume in the lungs? Decreases. Pressure increases even further, and more air comes out. Okay? So those are accessory muscles. So forced inhalation uses pectoralis minor, uses sternocleidomastoid. Exhalation uses internal intercostals, external for normal restful breathing, internal intercostal as well as the abdominal muscles. Forced exhalation. Okay. These two will increase that volume change even further. Right? So here it will increase the volume of the chest wall, chest cavity, which decreases pressure even further. Here it's going to decrease volume even more, which increases pressure even higher. It increases pressure, so it's going to come out. Any questions? Okay, so please be able to explain inhalation and exhalation. Let's involve how it changes volume, how it changes the pressure and intensity. So compliance is basically the resilience or the ability to expand. Lower the compliance, the more difficult it is to expand. Okay? Emphysema does that. We talked about the respiratory distress syndrome. where alveolar collapse will also make compliance decrease. If there's any problems with ribs, if I had a stab wound, I'm not going to be wanting to expand those lungs. So compliance will decrease. Spinal cord damage can also affect compliance. Any questions? Okay, next we're going to talk about volume changes during breathing. Okay, so if you could, please draw with me and leave this up. Okay, so we're going to talk about lung volume changes during breathing. First of all, let me make sure we can see, understand what the y-axis. So this is lung volume. Okay, so 0 is going to be right down here. Do we start with 0? No, there's always some volume of air left in. Okay, so we'll never get to 0 first. Okay, but let's start with our breathing, right? If I say this is the change during one cycle, okay, this is 2 cycles, one cycle. When did this volume increase? This is during inhalation and it's exhalation, right? So just understand that's when it increases because we're talking about lung volume, okay? This amount of volume that we exchange during restful breathing here is called tidal volume. Tidal volume is the volume of air that's is exchanged during restful breathing. Okay? Now if I took a deep breath in, which way will this graph go? Upwards or downwards? Upwards, right? Because it's talking about lung volume. There will be a maximum I can breathe. Okay? So next one we have to also pay attention where it starts. It's actually going to start at the highest point here, and then it's going to be about. Okay? This is called inspiratory reserve volume. We go back to normal breathing for one rotation, and then we do something else. So this is called inspiratory reserve volume. Okay? So how we describe it is the additional volume, the additional volume of air that can be inhaled after restful inhalation. Okay? It's called inspiratory reserve volume. There is another name from here upwards. We don't need to know for upwards. This is basic principles. This is stop here. Okay? This is inspiratory reserve volume, the additional amount, the additional volume of air that can be inhaled after restful inhalation. Okay? And then say I decide after I have been breathing normally, I'll breathe the maximum out. Okay? Again, it will not go down to 0. This, again, after normal exhalation. This will be called, what do you think? Expiratory reserve volume. It's the additional volume of air that can be exhaled after restful exhalation. We're 2 more. Okay, it's the additional volume of air that can be exhaled after restful exhalation. Expiratory reserve. It's a reserve. The next one is from the maximum we have exhaled to 0. This is called residual volume. This is the volume of air left in the lungs after maximal exhalation. The volume of air that remain in the lungs after maximal exhalation is called residual volume. Okay? It's roughly about 500. If we have emphysema, that's going to rise up. They're going to have even more of a residual, more trapped air in their lungs. So you're going to have to liter up, half liter, 1.5 liters of trapped air that they cannot save. Okay? So residual volume is the volume of air left in the lungs after maximal exhalation. Then the last one is called vital capacity. Okay, this is the maximum amount that can be exhaled. So you can either start from the bottom and go up in the explanation. So maximum volume of air that can be inhaled after maximal exhalation. Or you can go the other way too. Basically maximum to maximum. That's called vital capacity. That's the maximum amount of air that can be inhaled after maximal exhalation. This depends on our height, generally depends on other factors like how much fat is in our chest wall, how much muscle, those or both will decrease the vital capacity as well. I think we will have a chance to at least check the vital capacity in the lab during the respiratory lab. The others we do not have the equipment. We need a good spirometer to be able to measure all that. Just have this handheld one which will measure vital capacity. Okay. These are basic ones you want to be able to recognize and understand, and what happens in certain illnesses, and could be able to explain what's happening when we know what's in CO emphysema, there's a lot more trapped air, so their residual volumes will be quite explanations, vital capacity, maximum air, inhale after maximum exhalation, really describes it. We do have residual volume up to about a liter, very higher emphysema. Cannot completely, this is going to be important when we talk about partial pressures, right? Partial pressure of CO2 within our alveoli is different from the same thing with the oxygen too, it's different from outside because of that residual Here's an image of the same thing that's showing all the measurements. So let's talk a few more things about that diffusion, right? And gas exchange. Any questions there? Sorry. The slides are basically explained here. Okay, so In terms of gas exchange, a couple of things, right? So we want the respiratory membrane to be nice and thin, right? 1.5 to 1 micrometers. That will allow things to diffuse. But we also have these partial pressure. Basically, if you think about a mixture of a gas, I said the imaginary cube has 100 molecules of total molecules of gas, 80 are oxygen, 20 are water, right? So partial pressure, this is Dalton's law, it explains that the total pressure exerted by all the molecules together is individual pressures of those molecules separated out. So for example, that 100 molecules, the pressure can be separated out to the 80 molecules what they exert and the other 20 molecules what they exert. Partial pressure is this component split out. Okay? And in the air we breathe, what's the main component in the air we breathe? Nitrogen. How much is nitrogen? About 78% is nitrogen. What's the next most common? Oxygen. How much? 21%. It's 1%. Everything else, even CO2 is very small. Okay? It's about 0.03%. So if the pressure exerted by individual ones, that makes up our atmospheric pressure. What's the atmospheric pressure at sea level? The 7 some number, yes.
750?
Oh, 760 millimeters of mercury. Okay? We're going to talk about partial pressures in this case. So at sea level, atmospheric pressure is 760 millimeters of mercury. We also need them to move from that gas state into a liquid, into our blood, right? So there's something blocking that make it difficult, right? It's the water on the alveolar surface that helps with transmission, okay? And movement or diffusion occurs as long as there is a pressure gradient. If there's a pressure gradient, we go down the pressure gradient. Once it equilibrates, there's no net movement of those molecules. So, what are some things to remember? So at sea level, atmospheric pressure is 760 millimeters of mercury. It depends on each one. So if we say 21% is oxygen of this 100% of atmospheric air, then out of this 760, 21% is the partial pressure of oxygen. Roughly about 160, I think comes out with calculations if somebody wants to do that. It's about 158 or 59. Nice round number is at 160, 21%, 0.21 times 760. Right? This is partial pressure of oxygen in air. Okay, it's a precipitation. So, what do we need to remember? It is different in, first of all, blood, right? When the oxygen poor blood comes to the lungs, it's going to have a lower amount of oxygen than the pulmonary veins that take it away. Okay? While the CO2 is going to be the opposite. When it's coming in, it's going to be higher than lower. But please also, I don't have it in this slide, but please also note, in the alveoli, we're not going to have that 160. So if I did oxygen, partial pressure of oxygen in air, it's about 160 millimeters of mercury, while the partial pressure of CO2 is going to be a lot less, 0.3%. I think it comes to about less than 1 millimeter of mercury. Okay? But within the alveoli, the numbers are different because of residual volume. There's a lot more CO2 in our alveoli. I'll talk about it in a second. It actually becomes 105 and 40. Okay? A lot higher. This is in the alveoli. Okay? So we need a gradient, blood that's coming in the pulmonary arteries as a PCO2, partial pressure of oxygen about 40, while PO2 of 40, PCO2 of 45. So this 45 will go down to this area where there's less, whereas oxygen will come from our alveoli into this area. Okay? So here, because of the timing, it doesn't get up to 105, it stops at 1. Okay? But the CO2 does drop to pretty much the same as the alveolus. Okay? And I think I have an image here, you can see that, I don't know how clear it is. Here it's actually put us under to be about 105, but anyway. So higher oxygen in the alveoli, lower CO2, but it's still much higher than atmospheric air thanks to this residual volume. And when we're normally breathing, that is even more, right? There's even a lot more unexchanged volume. Okay? That's why this is high. CO2 is high there. Okay? Still, it's higher oxygen here compared to the blood, a lower CO2 here compared to the blood, right? So this is pulmonary capillary, pulmonary artery, bring oxygen poor blood, so CO2 will move out, oxygen will move in, the blood leaving will have a PO2 of about 100, PCO2 of 4. In tissues, it's the flipped, right? So here is the blood, same blood that's coming here, but in tissues, PO2 is about 40, PCO2 is 45. Okay? So we have CO2 from the tissues going to the blood, oxygen from the blood going to the tissues. When it leaves the systemic veins, it looks like that. Similar to it arrives at the lungs through the pulmonary arteries. Okay? So it drives the difference. It drives oxygen from our alveoli into the blood, and CO2 from the blood to the alveoli. In the tissues, it's in the opposite direction. Oxygen from the blood, it's higher here, can go into the tissues. CO2 high in the tissues, it's going to go into the blood. Any questions? Okay. So how do we transport it? So oxygen is transported 2 ways in our blood. 98% is bound to hemoglobin. And it becomes oxyhemoglobin, by the way. This is what gives that bright red color to blood, which is oxygen rich. It's this heme group when it's attached to oxygen. While less than about 2% is transported in blood plasma. Okay? So 98% transported bound to hemoglobin within erythrocytes, bound to hemoglobin. How many hemoglobin molecules is roughly in each erythrocyte? This one I believe is about 250 million, right? How many oxygen molecules can one hemoglobin carry? 4 heme groups, they can carry 4 oxygens. Okay, so you can carry up to 1 billion oxygen molecules in one red blood cell. Well, carbon dioxide, carbon monoxide poisoning, why is it dangerous? Binds to hemoglobin, binds irreversibly, right? It's a stronger affinity. Whereas carbon dioxide also binds, but if oxygen comes in, it's like, okay, I'll move away. It's your turn now, kind of thing. But carbon monoxide will not. Right? It will bind to it. And why is it, another reason besides, why is it difficult to detect?
Because the pulse ox just picks up what's binding to hemoglobin.
Good point. That's for us, yeah, clinicians, but why do the individuals, the patients not detect CO? There's no smell, colorless, and odorless as well. Where colorless they can't see as well. What are something that produces carbon monoxide? Motors, any sort of thing that's burning fuel. okay? Whether it's a car that produces carbon monoxide, right? Furnaces, boilers, they'll produce carbon monoxide, right? As long as it's vented properly, it's not a problem. And there is usually a little bit, small amounts is fine. We can handle that, but it's when we have a lot more we can, right? And usually there is symptoms. Yeah, initially there's flu-like symptoms, and then there will just pass out. Okay? You have headaches, you have nausea, feeling fuzzy head, but it's great. I'd say it's accounted for roughly about 200 times greater affinity to binding to hemoglobin. What's the treatment? Can we just put them on oxygen? It won't really do a lot, but it will hopefully make sure that they have good oxygen supply, but it's not going to do anything to that CO bound to it. What's the treatment?
Hyperbaric chambers.
It's hyperbaric chamber. In the hospital, they put it under high pressure, so we want even greater difference in that PO2. That's when it can kick out the CO from hemoglobin. Okay. Well, carbon dioxide is transported 3 ways. 70% of carbon dioxide transported is transported as bicarbonate ions in blood plasma. Okay, 70% is transported as bicarbonate in blood plasma. I'll talk about how it forms in a second. Let's just talk about the other two. The other is bound to hemoglobin. That's the next common one, and then dissolved in blood plasma. Okay, so 20% bound to hemoglobin, 10% just as dissolved CO2 in blood plasma. Let's go back to this 70%, right? It's CO2 plus water gives us carbonic acid, right? When it splits up, it gives us hydrogen ions and bicarbonate. So what's interesting, if you think of it, maybe you won't find it, the CO actually enters the red blood cell. The enzyme's actually found within the red blood cell. Okay, it catalyzes the reaction, bicarbonate is formed, and leaves the red blood cell. When we go back to the lungs, opposite happens. The bicarbonate now goes into the red blood cell, it's going to bind to H plus ions, you're going to have carbonic acid form, and then it goes this way, carbon dioxide is then released, and then the exchange happens. But it's the same enzyme that catalyzes to both opposing reactions, just different from usual enzymes. This is an exception. So, 70% transported as bicarbonate ions in blood plasma. Okay. So let's talk about respiration. Okay, so we have some respiratory centers located in medulla oblongata. Pons is for the respiratory reflex. Okay. What can they do? And we'll talk about things that can stimulate it, but when they do, they will increase or decrease respiratory rate. What are we most sensitive to? Low oxygen or high CO2?
High CO2.
It's high CO2. Are we also sensitive to acidosis in blood? Yes, in terms of ranking, that actually comes in second. Low oxygen actually is ranked third as a trigger for breathing. Okay. High CO2 will trigger us to breathe faster. Low oxygen will also, but we are more sensitive to the CO2 levels than oxygen. And the next one is actually acidotic levels. Okay. We can also increase respiratory rate. Some medications, some stimulants can cause that. Body temperature that rises during fever can also trigger respiratory rate to increase, even without introducing CO2 or oxygen. Right? If we have fever, and we've got viral infection, we're going to need a greater amount of oxygen. So it's a response even before the levels change. Anticipating response. So what are some ways in which respiratory centers active? So mechanoreceptors, we are found in the lungs, which can also be sensitive to pressure. This actually talks about perfusion ventilation ratio, the too much for us. I'll just talk about it. So if there's an area that's supplied with more blood, okay, we want that area also to be supplied with more air, right? That way we have a good exchange, right? And of course, if there's an area that's not receiving a lot of blood, we'll actually not need to, we'll actually constrict the bronchioles to that area, will not supply that area with a lot of air to, okay? We're trying to send it to areas where we can get the most efficient exchange. That's why these mechanoreceptors are present, to detect those changes in pressures of blood to supply. If there's more blood coming in, then we'll send more lung volume. And simultaneously, if I expand my lungs, that will also attract or stimulate blood to come to that area. Okay. Again, trying to balance out ventilation perfusion. So good exchange. Chemoreceptors, as I mentioned, is sensitive to CO2, acid, and oxygen. Not all. CO2 is the most highest stimulant. Then it's acidosis, because if you're acidotic, what is it going to do? Breathe faster. How will that reduce acidosis?
Carbon dioxide.
Yeah, remember carbon dioxide equals acid. It's called carbonic acid because it produces acid. So if I blow off CO2, I'm kind of getting rid of acid. Okay, so I'll trigger respiratory rate increases. Okay, so we are more sensitive to CO2 than pH, than only oxygen. Right? In terms of our receptors in our brain response to the changes. Carbon dioxide is the most powerful factor. So let's talk about why it's not a good idea to put COPD patients on 100% oxygen. Any thoughts? So end stage COPD, early stage it's fine. They usually are prone to be a little acidotic.
They tend to retain carbon dioxide, so their body now is a hypoxic gland instead. So if you give them too much oxygen, it could compromise that.
Very good. Yeah, that's good. So they do run at a higher CO2. Their brain actually gets accustomed to that higher CO2. So when it only goes a little more than that, will it stimulate more breathing? When we give them oxygen, what's happening to the CO2 levels? They'll start to drop. The brain's like, you're breathing too much. You're exchanging too much oxygen. You're getting more CO2. It actually shuts it down. So end-stage COPD, we should not put that at 100% non-breathable non-rebreathable mass, because actually going to take away the stimulus for them to breathe, because their stimulus is that higher CO2. By putting on 100%, actually reducing that CO2 levels. Okay, that's the most powerful. So, in terms of what else by higher symptoms, right? So if you're excited, what happens to our breathing rate?
Increase.
Also increases. Limbic system also increases, right? Can we voluntarily increase and decrease breathing rate? Yeah. Like singing, we actually have those nice to sing. Quickly take a breath, then hold the breath a little bit, sing whatever you want. I can't sing, so I'm not going to try, sorry. And then we can control that, right? But we can't hold it for too long, because then our CO2 levels will go up, and the brain will say, nope, I need you to breathe. We need to exchange that. Right? We talked about limbic system also can alter the rate and depth. What does a depth mean? Depth of respiration?
Volume.
Yeah, how much volume is being exchanged, right? Yes, we can change the rate. We can breathe faster or slower. We can also increase the volume that we exchange as well. So let's talk about hyperventilation, right? It's a symptom of what kind of a situation? Anxiety attack, right, or panic attack, right? They will, what does it mean, hyperventilate? They're breathing, the exchange is at a higher level, right? What's that gonna do to the CO2 levels? Go down. What's that gonna do to the stimulus to breathe? It's gonna say either slow down or even pass out. They actually do, some people hyperventilate to a point where they actually pass out because brain's like, okay, my CO2 levels are too low, and you stop breathing, then my CO2 levels will be at a normal level, right? So they do pass out as well. What are some signs of this thing? So it's really not voluntary. If we do it voluntary, we can try this in lab. I don't think we didn't get to do that in the acidosis alkalosis. We could have tried, actually we did try, right? In this class? No? What did we do for the acidosis alkalosis? We just tested the buffer?
Mhm.
And then we just talked about possibly, if we try to hyperventilate on demand, it's not really effective. We might be breathing faster, but we're actually working on muscles faster too, so we are producing CO2 at a higher rate as well. So generally we do not see CO2 levels go down. So this is actually involuntary, right? So that will lower the blood carbon dioxide levels. Some symptoms are tingling around the mouth and fingertips is common. They can even go to a tetany, which is a contracted state, and also they will stop breathing. Cessation of breathing, apnea can also result. Why, as a treatment, we may suggest breathing into a bag? Yeah, it does two things. One, you're going to breathe out CO2, and then when you breathe back in, you're breathing at a higher amount of CO2, again trying to maintain CO2. Another thing it does is makes that person aware of their breathing. When they do that, they'll also try to slow it down by that process. So it does both things. So try that. Next is COPD, which stands for chronic obstructive pulmonary disease. It's actually a group of illnesses. Emphysema and chronic bronchitis are the top two which fall in this category. They have very similar symptoms, but the etiology, the way it came about, is slightly different. Or the pathology is different, etiology can be the same. So in terms of chronic bronchitis, what do you think is happening? Inflammation of the bronchitis chronic, right? The definition is 3 months or so of continuous sputum production. Okay. While emphysema, there is actually damage to pulmonary alveoli, so you're getting a lot more dead space. You're also getting these larger pockets of air in there. Okay. Both of it has very similar symptoms and similar causes. It's number one is smoking and other pollutions. This can be even secondhand smokers also have been attributed to having this illness. Previously, even bartenders used to, because this in bars where smoking was allowed. What you might see as a symptom of this is they are trying to, there's something called air hungry, forcing air in and out, right? So you might see pursed lips when they try to breathe out, pinkish or even blue lips, skin and lips is where we see the most. In terms of treatment, there's maintenance, and then if there's an acute attack, we have to augment more treatments, right? So they generally are on some bronchodilators, generally on corticosteroids, usually inhaled until it becomes acute, then they may be on oral corticosteroids. Oxygen maybe, I've also seen this in people smoke with the oxygen tank, it is dangerous. So those are not doing that. They use nasal cannula, which is a slower rate, but we still do know, so we don't want to be 100% right. We talked about that. And then this could be, in the case of emphysema again, it has some benefits. If there's a big bulla, for example, that could rupture and cause pneumothorax, that's when we consider reducing it. But otherwise, again, there's no point removing something, even if it's not malfunctioning, it will cause any extra possible complications, because surgery itself is a complication. Okay, false complication. While TB, I'll just talk about it, it's not as common here, thankfully. It is by a bacterium called Mycobacterium tuberculosis. How is it spread?
It's an airborne illness.
It's an airborne from coughs, right? What is a typical cough for tuberculosis?
Gross.
Gross, yeah, why is it gross? What's gross about it? It's blood stained sputum, it's very common, for TB individuals, right? Coughing up, severe coughing of blood is very common. Weight loss because they're not able to breathe well, they're not able to eat, and then using up all their storage for breathing, right? Night sweats, fever is common. They very, as you can see, it's very severe, usually isolated. They are treated with heavy doses of antibiotics for a long period of time. Lung cancer, it is common, yeah, question?
Can tuberculosis cause your lungs to collapse?
Yeah, sure. Just like even pneumonia can, right? If there's a part of mucus which goes into one of the bronchi, blocks it, that whole part collapses. So it blocks. Tuberculosis can also cause inflammation because that can cause lung collapse. Then lung cancers, again, number one cause is smoking, but other pollutants, especially if they're working in a chemical environment, not wearing any respirators or protection, that can increase the chance of illness, right? Again, what is cancer? Yeah, uncontrolled cell growth due to mutation, right? Uncontrolled cell growth or cell multiplication due to mutation in the DNA, right? We can diagnose that by X-rays, CT scans. What is metastasis? Spreads to other organs. What's the difference between malignant versus benign? Which one stays in one area? Benign stays within one tissue. Malignant means spreading other tissue. Metastasis when it spreads to other organs, right? Lung does metastasize to both, of course, lymph nodes, the bone, the liver, it can also metastasize. Once it metastasizes, then treatment becomes much more complicated. It stays in the lungs caught early, then it's a lot more, it can be curable even with half lung, whole lung, depending on how early it was. Once it starts metastasizing,